I want to thank you very much for the invitation to Ramal. It was a very short invitation, and I had to manage to get the lecture D prepared to update it أنا قلتها قبل كده again it's a pleasure to be here without a mask كمان for a change, and then I was asked to talk about stem cell transplantation for beta thalassemia major. And everybody knows thalassemia is a disorder that is associated with defective synthesis of alpha or beta globin subunits that is related to the point mutation or deletion of the alpha globin genes located on chromosome 16 or beta globin gene located on chromosome number 11. Again, thalassemia is the most common inherited hemoglobinopathy, and unfortunately, geographic regions with the highest prevalence are often those with the lowest level of socioeconomic status. The treatment options for beta thalassemia include chronic blood transfusion, iron chelation, hemoglobin F inducers, plus Patirept, and again, recently, whether gene therapy or gene editing, and lastly, allo stem cell transplant. Up to me and in this area, allo stem cell transplantation is the only available curative option up till now. And according to Lucarelli et al., their overall survival exceeds 90%, and the thalassemia-free survival exceeds 85% for risk class 1. Again, the first allo transplant for beta thalassemia major was reported in 1982 by the Pizarro group. This is the New England article that was published, I believe, 1 year ago, and they suggested an algorithm where patients who were eligible for transplantation and under the age of 12 and having a matched sibling donor, they should be offered one. Again, for those who are above the age of 12, we should consider stem cell transplantation if they are in a good shape, and I'm going to talk about it later. Again, if you don't have a matched sibling donor, and I'm having a problem with that, the authors, including Dr. Tahir, they suggested that we should consider for patients under the age of 12 an unrelated donor, a cord blood, or a haploidentical transplant. Again, for those who are above the age of 12, one should consider gene therapy. Regarding the cost, and I'm following the footsteps of Dr. Khalaf, the estimated cost for an allo transplant from a sibling is invariably lower than that of conventional therapy. And in UK, the approximate cost of an allo transplant is equivalent to 8 years of conventional therapy. So if we're gonna treat patients for 8 years, then it's going to become cost effective. The transplant, and here the transplant is much cheaper than in UK. Again, for a transplant, we need a donor, and matched related donor are available only for 25% of patients. Again, matched unrelated donor can expand the pool by 50%, but they have to be 100% match, and it has to be high resolution molecular typing patch. And the introduction of anti-thymocyte globulin into the conditioning improved the outcome for patients who are undergoing an unrelated stem cell transplantation for beta thalassemia. However, we're lacking registry here. Again, for cord blood, and you're very familiar with cord blood, for matched sibling donor, thalassemia-free survival did not differ between cord blood unit that has to be fully matched and bone marrow. So it's not any cord, it's a matched cord, related cord. The outcome is exactly the same, and you have to have enough cells in the cord unit. So it would be the same like the bone marrow. For unrelated cord blood transplant, there were higher rate of graft failure and delayed recovery, and it's not considered an option, at least for me. Again, expanding again or extending the donor pool again by adopting haploidentical transplant. And one may consider T34 positive selection haploidentical transplant. However, it was coupled with a 27% graft rejection rate. Again, when you adopt a CD19 alpha beta T-cell depletion haploidentical transplant, there was an improved graft rejection rate. However, it was coupled again by delayed immune reconstitution and post-transplant lymphoproliferative disease, and one would expect a higher transplant-related mortality. And as elaborated elegantly by Dr. Khalaf, the problem of haploidentical transplant mainly related to the intense bidirectional alloreactivity resulting in high incidence of graft failure and severe graft versus host disease. However, post-transplanti could mitigate both graft rejection and GVHD without being toxic to the donor stem cells. When you adopt in haploidentical transplant a T-cell replete technique, it is coupled obviously with an increased incidence of graft versus host disease. Again, for a T-cell depleted haplotransplant, they have a much less GVHD, but they face more rejections and delayed immune reconstitution with infection, with opportunistic infection. Again, coming back to the Pizarro experience, and again, everybody knows about the risk classes that were initially suggested by Pizarro. There are many risk classes, however, this is the most common, where patients are classified into 3 risk classes according to the presence or absence of hepatomegaly, portal fibrosis, and history of inadequate chelation, where risk class 1 has no risk factor, risk class 2 has 1 or 2 risk factors, and risk class 3 is having all 3 risk factors. This is the outcome by Pizarro, as I said, where you have a thalassemia-free survival for class 1 of around 87% and 81% for class 2 and around 60% for class 3. Other predictors of outcome: age. Patients who are under the age of 14, they do better than those who are above the age of 14. Again, if you're having a young patient who's having a matched sibling donor, we should offer him a transplant ASAP. Again, stem cell source, the main stem cell source should be bone marrow, because peripheral blood could lead to an increased risk of chronic GVHD. So whenever it is possible, one should take a bone marrow harvest in thalassemia rather than a peripheral blood stem cell collection. Thalassemia stem cell transplantation in adults, it remains, the experience, it remains limited, and whenever you're having an adult patient who's in a good shape and well clated and having a matched sibling donor, you should be offered a transplant, but should be within a controlled trial. Again, matched unrelated donor would get you almost the same outcome like a matched sibling. However, we need a full match with a high resolution molecular typing. Lastly, a mismatched family donor carries a worse outcome, and the experience remains limited. Some aspects regarding thalassemia and transplanting thalassemia, it's different from hematologic malignancies. In a way, you don't need to eradicate a malignant clone, and graft versus malignancy is not warranted, and their immune system is intact. So there is a possibility, as elaborated by Dr. Khalaf again, to develop, because of the repeated exposure to blood transfusions, to develop anti-HLA antibodies. And I believe for risk class 3 at least, and even if we are going to do a matched sibling donor, patients should be tested for donor-specific anti-HLA antibodies, because they can end up in rejection like when we do haplo. A stable mixed chimera is not acceptable in the malignant setup. However, again, if you're maintaining good hemoglobin and stable mixed chimera, this is a very successful transplant when it comes to thalassemia. The conditioning regimen, it should be a myeloablative and capable of eradicating the thalassemic clone and suppressing the immunity so you can have a sustained engraftment or take. Again, usually the conditioning contains busulfan, so it's a major drug that we are using. And recently they introduced, and they like it very much in Germany, trisulfan instead of busulfan. Reduced intensity conditioning in beta thalassemia, I'm totally against again. We tried it early on, and it was coupled with transient incomplete engraftment and ended up in rejection. These are the most common conditioning regimens we are using, including busulfan cyclophosphamide and busulfan cyclophosphamide ATG. And as I said, trisulfan was recently added into the conditioning. The first large series was published in the New England Journal of Medicine by Pizarro Group in 1990, and they reported a mortality of 6% and a rejection rate of 0% for class 1 thalassemia. Again, a mortality of 24% and rejection rate of 35% for risk class 3 beta thalassemia. Again, in another study that was published in 2012, the introduction of anti-thymocyte globulin with conditioning managed to reduce the graft rejection rate, and adding trisulfan in the conditioning regimen managed to improve the outcome of the risk class 3 patients with a mortality of 13% and a rejection rate of 8%. Haploidentical transplant, and again, Dr. Khalaf talked much about, and whether you're using, as I said, CD34 positive selection or CD19 alpha beta negative selection or post-transplant Cy. It is coupled with increased rejection rate, increased GVHD rate, and probably a higher mortality rate. And like the recommendation in the New England Journal, it should be currently confined to limited centers with experience and within a context of a clinical trial. Yet, this is the trial that Dr. Khalaf was talking about when they used two immune desensitization courses before going into what is known as reduced toxicity conditioning and post-transplant Cy, and a very high event-free survival. Yet, it is too good to be reproduced, and I would take these results very cautiously, at least for now. We'll move very fast back to the Nasser experience, and allo-BMT for beta thalassemia in Nasser represents like 10% of the total number of transplants done. Again, in the pediatric age only, it is double, and it represents like 20% of the indications. In the study, we included almost 350 patients. Their median age was 5.2, and predominantly males, 215 males and 133 females included. Again, the main conditioning regimen we use is busulfan cyclophosphamide ATG in 74% of the patients. Again, cyclosporin A methotrexate and cyclosporin A steroid are the main two graft versus host disease prophylactic regimens we are using in our center. This is the conditioning regimen. Originally, we are using busulfan, and it ranges between 16 and 20 milligram per oral. We did not use at that time, and still, the IV BU because of the cost and unavailability. Again, cyclophosphamide as an immune modulator, and earlier we used ATG 110 milligram per kilogram over 11 days. This is our graft versus host disease prophylactic regimen, including cyclophosphamide and short course methotrexate, plus minus anti-thymocyte globulin. This is our overall survival for the whole group, 77.6% at 3 years, and the transplant-related mortality was around 21.3%. When we did multivariate analysis regarding the factors that are having an impact on outcome, this class 3 and HCV and abnormal liver function were the only factors that had an effect on outcome. Again, acute GVHD encountered in almost 14% of our patients, while chronic GVHD in 7% of our patients, and this is attributed to the use of ATG. Again, the most common causes of deaths were related to sepsis and GVHD, and rejection happened in like 4% of patients. And it's important that you keep following the chimeric kinetics by doing the NTRs, and we used to do it monthly in the first 6 months, and then at the end of the first year and the end of second year. And if you achieve a stable mixed chimera for 2 years, then probably they are not going to reject. To conclude, stem cell currently remains the only economic available curative treatment, and cure appears to be lifelong, with an overall survival of above 90% and a thalassemia-free survival of above 80%. Donor selection is of utmost importance. Again, early transplantation is a key factor for transplant success. Myeloablative conditioning is the standard, and cyclophosphamide mixed-state is the gold standard for GVHD prophylaxis. Coming to this point, I would like to thank you all for your attention and want to take questions. Thank you.